To start with, I need to just go back and tell you something about this clinic that has been for 25 years a work in progress and what we refer to as meaningful work. I said this not long ago, a new frontier of genomic medicine is to be found in the everyday practice of medicine. The clinic is where it needed to be. It was always intended to be a local medical clinic that provided care for those of Lancaster County who had complex medical problems, many of those inherited medical problems. This is the title of a talk that I gave not long ago at the University of Wisconsin. Also the title of a course that we teach at Franklin and Marshall College called Plain People in Modern Medicine. Plain People, Genomics, and the Art of Translational Medicine. Translational medicine just refers to this idea that through the Human Genome Project, we learned a great deal about the genetics of people, about the genetics of medicine. The problem then becomes, how do you use that information? How do you translate that information into medical care? That's translational genetics. We think that this clinic has become, in a sense, a model for the plain communities, a model to be replicated other places and other communities, but also a model for healthcare in a more general sense in terms of how you take information about genetic risks within populations that influences health and translate that into timely and effective care. It is true that the clinic was from the start to be a place that was accessible and affordable. We wanted to have accurate and cost-effective diagnosis, so rather than dependent upon sending samples to a university laboratory, we set up the university laboratory in Jakes Field. It's still one of the few places in the world you can get your leucine level measured while you wait. So if you have maple syrup urine disease and come into clinic, we draw a blood sample and we can run an amino acid profile in our clinic within 20 minutes. If we see a child who we suspect has Crigler-Najjar disease, we can draw a blood sample, separate the DNA, do targeted mutation analysis, and we get a diagnosis, a molecular diagnosis, faster than we get a bilirubin level measured at the local hospital. We have learned how to use technology in a primary care setting to make our medicine not only medically more effective, but economically much more affordable. We've always had the philosophy that the best opportunity to be helpful with many of these difficult problems we see is to recognize the condition when the child or the person is asymptomatic and try to prevent the progression of the disease. And in one of the disorders I'll tell you about, glutaric aciduria, which is what led me here, that turned out to be a critical concept, that you had to start with a healthy child to learn how to treat that disease, and you had to start with a healthy child to succeed in preventing the disability that is that disease. We always sort of felt like the work was valuable. In the communities when I went there, having benefit auctions to pay large hospital bills was commonly done. It was the way the community worked together to help pay for health care. We went to the community with the idea, why don't we have those auctions to prevent these hospital bills? Why don't we have those auctions to support a place that studies, learns about, and provides care for the children who need that care? Probably one of the best things we did was build a clinic that involved the community right from the start. We had a clinic raising. About 80 people got together on November the 17th, 1990, to raise the clinic. And I think it always did give the place a sense of its place in the community. And in Big Valley, we hope to do the same thing. Paul mentioned this young man. That's John Hostetler as a young boy. That pamphlet was written when he was working on his PhD at Penn State, and it talked about Amish life as he knew it in Big Valley. His book, Amish Society, remains one of the classic studies of the plain communities. It was this book that led John Hostetler to know Victor McKusick. He had submitted the manuscript to Johns Hopkins Press to see if he could get it published. He'd been turned down 25 other places, and Victor McKusick read the manuscript, recommended it be published, but also realized that John Hostetler would be a good person to know from the point of view of medical genetic research. And it was really that relationship between John Hostetler and Victor McKusick that began a history of research among the plain communities that began about 1963. And culminated in this book in 1978, the Medical Genetic Studies of the Amish. It was really a collection of publications that had to do with the disorders found within the plain communities. It was one of those books that established Victor McKusick's reputation as a young researcher in these communities, and that was important because he went on to be physician-in-chief at Johns Hopkins, the father of the Human Genome Project, was really a very important figure in the history of medicine. And I think it was always good for him to come to the clinic to see the work being done there, because I think it gave him a sense of payback to the community for what he had learned from the community. It was a way of delivering the health care back that was based upon the knowledge that he and John Hostetler and others had gleaned over the years. This is what dystonia looks like. This is what glutaric aciduria looked like. And at that time, 1988, this was considered one of the most rare diseases in the world. None of us at Children's Hospital of Philadelphia, where I was studying at the time, had seen this condition. I just happened to run a sample in the lab that made the diagnosis of glutaric aciduria type 1 in an Amish boy. Out of curiosity, I drove out there to examine him and talk to his family. I knew something about these famous populations, and they said, oh yes, we have a chain letter. We all know each other. This is the cerebral palsy of the Amish. And they gave me a list of names. And it was from that summer of 1988, just visiting farm after farm, that I began to not only see glutaric aciduria as a common problem within the community that produced a kind of injury that was almost always mistaken for cerebral palsy, but also got from that early history two very important observations. One was that this girl who was so disabled had a sister who was not disabled. She had the same gene mutation, she had the same biochemistry, she had had some developmental delays early in her life, but then she had gone on to be a healthy young woman, and in fact she is one of the young women who has shown us that a woman with glutaric aciduria type 1 can have children, and the disease does not affect her children. The second thing was that as I took a history from all these families, it was apparent that children often sustain this injury after a period of normal development. So they were normal when they were born. They might learn to sit up. The first child I saw had learned to cruise around and was walking. And then it was only suddenly, in the context of a minor illness, that this disabling injury occurred, and it often evolved over about an hour or 2 hours period of time, and they never recovered from that. Every one of those injuries took place before 18 months of age. So those simple observations, that children were healthy when they were born, that the injury often was an acute event caused by an infectious illness, that it happened before 18 months of age, and that it was possible to get beyond that critical period of risk and then go on into late childhood and adulthood without progression of the disease, that became the basis for the idea that this could be treated, that this disability could be prevented. It wasn't long until I realized that this condition was really distributed widely within the Amish population of Lancaster County, involved all the major family groups, and was what Victor McKusick would call a founder mutation. Biochemically, this is the disease. We have a mass spectrometer in the lab that allows us to diagnose this using a urine sample. The defect is in a gene called glutaryl-CoA dehydrogenase that is involved in the breakdown of glutaric acid. The bars on the left show what happened to the outcomes of children diagnosed early. So in the early 1990s, 95% of all the children I saw in Lancaster County were severely disabled with a movement disorder called dystonia. By the mid-1990s, we were preventing this disorder in half of them. We were preventing that injury. It is remarkable. Hugo Moser, who was one of my mentors around Johns Hopkins and sponsored this early work in Lancaster County, worked with a disease called adrenal leukodystrophy, which is a very difficult disease. And Hugo told me once that he'd diagnosed over 5,500 cases, had gone through dozens of therapeutic trials to try to treat those children and prevent the progression of that neurologic disease. And he died in his late 80s and never succeeded. There was a movie made about Hugo's life and his work called Lorenzo's Oil. In some audiences, people would be familiar with that movie, but it was a story of the effort to discover a treatment for that disease. The irony was that when I worked at Johns Hopkins and wrote a grant to study glutaric aciduria, I submitted that grant to the National Institutes of Health, and Hugo put in a competing grant for mine to buy Lorenzo's Oil. And anybody who knows the history would realize that Hugo got the funding to buy Lorenzo's Oil and Morton went to Lancaster County. It wasn't that funny at the time, but we both agreed as time went on that it was the best thing that could have happened to me and my wife. It forced us to think of a different way to try to solve this problem, and it forced us to think of setting up a practice in Lancaster County where we could not only provide care for these children, but would be present when they became ill. We could understand the basis of the disease and hopefully develop ways to intervene. By the early 2000s, we were successful 2/3 of the time, and today we're successful over 95% of the time. The key to successful treatment is in part early diagnosis, newborn screening. So the first newborn screening for this disease was done at the Clinics for Special Children in the early 1990s. And the rationale for screening was not that we knew how to treat it, but we knew by then we could never treat it unless we started with a healthy child. And the original screening was done by collecting urine samples that were brought in by the midwives and the grandmothers and the families and the local doctors and the local hospitals. And the sixth sample run through the lab was positive for glutaric aciduria. An Amish woman working at the clinic then talked the family into cooperating with me, and that was the first successfully treated case. The key of treating this disease really is a little more complex than I can explain in the 5 minutes I have for this now. And it was to actually to prevent the uptake of lysine into the nervous system. And we designed a formula at the clinic about 2005 that was based upon the principle of competing amino acids transported into the nervous system. And really what we did was restrict the intake of lysine in the diet, so put children on a low protein diet and an amino acid mixture that was devoid of lysine. And we introduced extra arginine, which competes with that amino acid and blocks the lysine from being taken up in the nervous system. That formula was designed by Kevin Strauss, who had come down from Harvard Medical School as a medical student in 1996 and brought with him a set of equations that we used to calculate transport values like this. And that became the key not only for glutaric aciduria, but for the successful treatment of maple syrup urine disease and another disease called MTHFR deficiency. I've often said that the work we do in Lancaster County is what should be called difficult learning. I used to give lectures annually at a camp in West Virginia called the National Youth Science Camp, and there were 2 students from each state, and these were outstanding students. They had never flunked a test. And I used to tell them, you know, if you don't have difficulty learning, then you're not trying to learn anything very difficult. Take my job for a while. You know, we failed a lot trying to treat this disease early on. And part of the key to the success was not always being successful. It was the tolerance of failure and the idea that we had succeeded some, but we just needed to improve that. This is kind of a diagram that we use for talking about maple syrup urine disease and the competition for amino acids that enter into the nervous system. We've done 58 liver transplants at Children's Hospital of Pittsburgh as an elective treatment for MSUD. These are not all Mennonite patients. These are patients coming from India and Brazil and Saudi Arabia and all around the world to take advantage of this knowledge that you can control this disease, cure this disease by doing liver transplant. They're getting married, they're off their diets, they will have their own families, and life will go on for them. It's a pretty remarkable change. Learning to care for maple syrup urine disease was complex. When the clinic opened, half the children died from cerebral edema within the first 5 years of life. They would become ill with an ordinary infection, go into coma, would usually be admitted to one of the hospitals in Philadelphia, and then 12 hours later they were gone, brain swelling, herniation. We had to learn to control that. It was really a problem of what in medicine we call osmolarity. It was a problem that you had to control the osmotic concentrations of the blood during the therapy to lower their leucine level and retrieve them from coma. And it became sort of a fluid and electrolyte problem, but we solved that problem, and we solved it at Lancaster General Hospital, and we solved it because it just took days and days and tried to study and understand what caused that. So now we've had over 300 hospitalizations for children with maple syrup urine disease at our little local hospital, and none of them have died of cerebral edema. We've never had a death. It used to be that 7 days out of the patient's life each year was spent in hospital. Now we're following over 115 children with maple syrup urine disease. We would be very busy if we had 7 hospital days per patient per year of follow-up. Our hospitalization rate has dropped to 0.2 days per patient per year of follow-up. What's the value of that? We did those calculations not too long ago in a paper in the American Journal of Public Health where we talked about not only the value of our work in terms of better outcomes, children growing up and becoming workers and having their own families, but also in terms of the cost. We could run the clinic taking care of 115 children with maple syrup urine disease, and nobody would ever question that it was valuable enough to do that. This child shows the acute intoxication of maple syrup urine disease. That's actually a depletion of brain dopamine and serotonin that produces that movement disorder. If we just give him some tyrosine, he will relax. And the graph on the right side shows the unbalanced uptake of amino acids into the nervous system. The big tall blue columns are leucine and isoleucine, and the other amino acids, which are essential for brain function, are being blocked out by the high leucine. This little child, she actually had chronic valine deficiency, and all I had to do was give her about 40 milligrams per kilogram of valine, and we were able to pull that feeding tube out. Her head started to grow. She started to develop, and if she walked in here today, you wouldn't really know she's different from other children. She's a little hyperactive, has a little bit of attention deficit problem, which is the price of being in valine deficient state for many years. This is a child from Honduras who found his way to the clinic. He shows all the signs of really severe essential amino acid malnourishment. About 2 weeks at the clinic on a formula that we developed to correct these problems. This is what he looks like. Worldwide, the most common cause of mental retardation is malnutrition. And this is the histology on the left of a brain that has been protein malnourished. The mental retardation of maple syrup urine disease and PKU and other disorders of amino acid metabolism where there's unbalanced transport of amino acid, unbalanced nourishment of the nervous system with amino acids, has this histology. What we learn about these conditions, I always remind students, these are bad conditions because they interfere with some fundamental biological system or process. And as you study these conditions and learn, you learn things of fundamental importance in biology and medicine. And MSUD is one of those conditions, if you studied nothing else, you would probably learn all there is to learn about medicine just studying that one disease. Other things that you learn by working within these populations that were unexpected. This is the retinal hemorrhage of a case. Her parents were accused of shaken baby syndrome, of child abuse. She, in fact, died of an intracranial hemorrhage and had retinal hemorrhages from vitamin K deficiency. Now, not many pediatricians really remember the history of vitamin K deficiency, but it was a terrible problem in the 50s. Given the rate of births in Pennsylvania today, if we did not give vitamin K to newborns routinely, we would see about 2,500 cases a year of vitamin K-related hemorrhagic disease of the newborn, and many of them would present with retinal hemorrhages and big intracranial hemorrhages, and some of those would be mistaken for child abuse. She had an underlying liver disorder called tight junction 2 protein mutation. We now know what that mutation is. We know there are dozens of adults and children within the community that have this disorder. We know it is one of the most treatable conditions there is. All you got to do is give them a little vitamin K and vitamin D and vitamin E and vitamin A to make sure that they don't malabsorb these important fat-soluble vitamins, and their outcomes are perfect. It's a highly treatable disease. In these communities, and in all communities, there's actually a differential diagnosis of late-presenting hemorrhagic disease of the newborn, and this is it for the Amish and Mennonite communities. These are the kinds of things that a clinic like ours learns about the genetic risks within a population that affect outcome, and with knowledge of that, gives us an opportunity to intervene and prevent the kind of problems that we see, that we saw in this case. We will always have children within the community who have diseases we can't treat. This little boy, who I wrote a story about many years ago, has what the Amish call chicken breast disease. When I first saw this boy back in the early 90s, none of us had any idea what this condition was or why these children went into respiratory failure. The chest was normal when they were born. The children actually seem pretty well. Intellectually, they're quite bright. And I put up here, don't forget the chocolate, because the last time I saw this child, I had gone through the house and passed out Hershey's chocolate bars to all the kids as I walked through the house. And when I was getting ready to leave, this little boy was crying, and I said to his father, "Why is he crying? I didn't draw any blood from him or bother him in any way." He said, "Because you forgot to give him chocolate. He wants chocolate too." This is still a lethal disease. In the mid-90s, working with National Institutes of Health, we were able to map this disease. We know that the mutation is in a gene called troponin 1. J.P. Jin, who's the chairman of physiology at Wayne State University in Detroit, has just published 2 books that really grew out of his work on this disease. He has dedicated 15 years of his career to looking for a way to substitute the mutated troponin with cardiac or other muscle troponins. That will be the cure of the disease. He knows exactly what needs to be done to treat this disease, and he's worked for 15 years to do it, and I believe he will eventually do it. So part of what we do in trying to help children with diseases like this is learn the basis and then recruit the interest and the experience of physicians all around the world who take an interest in these unusual problems and help them help us find solutions. What's the value of that work? Well, if you go to Children's Hospital Pittsburgh with a child with a neuromuscular disease and you get the workup to try to find out what it is, and some of the people in this room have gone through those workups, it cost you about $17,891 when we priced it out a few years ago. When that child comes to the clinic with a simple physical exam, we see the tremor. We know what the likely diagnosis is. We have the mutation. It costs us $50 to do the diagnostic test, and we make money charging $50. It's a very inexpensive diagnosis. I went through and calculated that we have taken care of about 287 children with lethal diseases over the last 25 years. We have spared all of them those kind of unreasonable workups. We have spared all of them long periods of futile care in the hospital. We provide the hospice care. We know what their fate is going to be, and we try with each one of these conditions to find answers, but until we have new answers, we know what their fate is going to be. It's some of the most valuable work we do. Just taking care of that group of patients, we estimate that we save the community about $5.1 million collectively in futile diagnostic workups and futile care. I'm often asked whether communities can afford to support clinics like ours. And my answer is immediately, you can't afford not to. That this is the way you can help those in need. Today, 3 pediatricians follow 2,600 patients with over 150 recessive disorders from these same communities. Were those communities underserved? Yes. Yes, they were. Within all communities of the world, these are not just problems of the plain community. I don't need to tell you that. Cerebral palsy is a label. On the right side, you see the differential diagnosis of cerebral palsy in the Amish and Mennonite populations. Mental retardation, same thing. Epilepsy, same thing. Sudden death, same thing. All these conditions that we used to think were a diagnosis are just the end result of underlying conditions, and once you know what those conditions are, you know what you can help and what you can't. There are actually 3 different disorders in the Mennonite community that produce the kind of movement disorder that we had, which is generalized severe dystonia. One is a dopamine transporter defect, one of the most difficult diseases to treat. The family who sent me here has a child with a dopamine transporter defect, and that just means that when the brain releases dopamine, the nerve cells can't take it back up and inactivate it. It produces a severe dystonia, a severe movement disorder that we can't yet treat, but we know precisely what it is now. There's also Sagawa disease, one of the most treatable forms of dystonia in the world. Responds to L-DOPA, which is used to treat Parkinson's disease. The condition we see here that we've just found recently is called Aicardi-Goutieres syndrome. It's an inflammatory disease that causes injury of the basal ganglia, usually in the context of a minor infectious illness, not unlike glutaric aciduria. It is my feeling that this will be a treatable disorder, just as glutaric aciduria was. But we have to find the children before they're disabled, before the basal ganglia is destroyed, and we have to understand how to control that inflammatory process. We will only do that if we find these children within the community, find out who's at risk, and now we can do that. This is a simple test. So I'll finish up just by giving you a sense of what we've learned. When I went to Lancaster County, very few of these conditions were recognized in either the Amish community or the Mennonite community. Now we know they're there. We know that 50% of these are highly treatable disorders that really should not cause disability. Now people say, wow, isn't that a lot to remember? We got to remember in the human catalog of recessive diseases, there are thousands, about 5,500 recessive diseases. We're fortunate. In our populations, we only have to know about 150 of them. And we understand how those 150 disorders put the children and adults that we take care of at risk. It allows us to anticipate those risks, and it allows us to be more effective in treating the ones that are treatable, and it allows us to be honest and realistic about those that we can't yet treat. It is this kind of thinking about how you go within a community, a small community. It could be South Philadelphia, it could be southern West Virginia where I'm from, it could be the American Indians, it could be the Manitoba Indians in Canada. You go within a community, and through working with that community, you understand what the underlying genetic composition of the population is that places the children and adults there at risk. And then you use that information to design your health care to make it more effective in terms of medical care, and more effective in terms of, of access, and more effective in terms of cost. Many of the solutions are quite simple, almost common sense. Glutaric aciduria was not that difficult to learn to treat. It was difficult to get to that 100%. But things have changed. In the state of Pennsylvania now, 152,000 children a year are tested for glutaric aciduria, and all of them are successfully treated, and most of them are not Amish. In the United States, 4.2 million children are tested for glutaric aciduria as newborn. Most of them are not Amish. All of them can be effectively treated. And worldwide, there are millions tested. It is now considered one of the most treatable disorders for pediatricians and geneticists. Things have changed. Things have improved. And I hope that when we gather here 25 years from now, we can look at troubles within your local community and say, that used to be a lot of trouble, but now we know how to care for it. Thank you. For glutaric aciduria, it is a stroke. So when we did MRIs of those children that I saw in the early 90s, we could see that the putamen, the part of the basal ganglia that's involved in Parkinson's disease, was gone. It had been damaged by a metabolic injury and low blood flow and was not recoverable. And it was really that realization that led me to say we will never learn to treat this disease and we'll never be successful in treating this disease if we don't see it before that injury takes place. And the disorder that we see here is the same way. The Aicardi-Goutieres syndrome, it's a mutation in that gene. The mediator is inflammation, and it causes swelling and then damage, injury of the basal ganglia, and then recovery is incomplete. And it's really the same kind of problem. They're just different triggers, and there are going to be different ways to prevent that injury from occurring. Other comments, questions? You know, in Indiana, where they set up one of these clinics like ours, it actually started in 1998 with Dr. Shapiro, who worked mostly with people with hemophilia and bleeding disorders, or excessive clotting, thrombosis disorders. And she set up a clinic there to take care of people within the Amish community with that problem. That clinic now serves the whole northwestern part of Indiana, not just the Amish people, but everybody in the community. And because of hemophilia, they set up a birthing center, which now serves the plain communities there, those who prefer to have babies in birthing centers. They set up a dental clinic to take care of people with hemophilia, but now they do $600,000 worth of work in their community with a dental clinic. And then they have just recently hired geneticists to do the kind of work we do within the community. And they did a survey of the whole state, church by church, family by family, to find out who had special needs and what the cause of those special needs was. So these clinics and the way the children make us think and work have become very important for communities. And there's a clinic like ours in Geauga County, Holmes County, and Wayne County now. They're setting up a clinic in Wisconsin. We're working on the one in central Pennsylvania. But there are about 400 communities spread across North America, and everybody should have a clinic like this, a community-based clinic for those with special needs. The community-based clinics then become an influence. So if the children who have the special conditions get their teeth worked on or get their shots, their brothers and sisters are more likely to also. So these become community health centers as much as places where those with special needs are taken care of. And I would say to the students here, there will be a lot of jobs in the future like this. Keep it in mind. We're always looking for people who are interested in this kind of work. Yes?
You mentioned the importance of early diagnosis, which I can well understand. What about diagnosing potential carriers or parents who may have children with these conditions?
Right.
What progress is there in that?
Well, there's a lot. So with maple syrup urine disease, we've been able to do carrier testing since the early 90s. Now that means that we can tell if each member of a couple has normal genes or one abnormal gene. If a member of the couple is a carrier, we will do carrier testing for young people who might be deciding whether they're going to get married. And then they might use that to decide whether or not they're going to marry that person, but nobody ever uses it that way. It's a community decision that you do your carrier testing after you get married to find out if you're at risk for having a child with maple syrup urine disease. But once we know that a couple's a carrier, then we test the baby when it's born, and like the girl in the picture, we take care of them at home. And the alternative is to wait until they get sick. They're rescued either because somebody recognizes they have maple syrup urine disease, or they're picked up with newborn screening, and then you've got about a $50,000 or $100,000 bill and about a 7-day hospitalization to get that child rescued. So the community has really gotten behind doing carrier testing in Kentucky and out in Ohio and other places. We get samples from all over the country to do carrier testing so that we can find those children when they're born, so that we can prevent them from having that first severe episode of illness. It's been very successful. The newborn screening program, which is done statewide, not just on plain people, the newborn screening program was in part tailored to make sure that we were picking up maple syrup urine disease and medium chain deficiency and propionic acidemia, conditions that are found in the plain community as well as in the general population. So that kind of screening is now done routinely here. And we've cataloged these conditions and the cases, and now with the tools of modern genetics, we can more often find the cause of the problem. And once you know the cause, and once you know the phenotype, once you can, as a physician, recognize the appearance or recognize some biochemical marker, then your diagnosis becomes very easy. So these slides, which I skipped over, just show something very interesting. If I see a Mennonite child with neurodevelopmental delay, this is the list of diseases that I have to think of. And I can, by physical exam, sort out whether this is primarily central cortical, or whether it's basal ganglia, or whether it's spinal cord, or whether it's neuromuscular. If I see an Amish child, the differential diagnosis is completely different. Just knowing that helps you as a physician. Your physical exam and the knowledge of what risks are within the population narrows your differential diagnosis to a very small number of things. So usually if we see a child with developmental delay, we're doing 3 tests to look for causes that we know within the community, within the family, that are most likely to cause that. Each population is different. So one of the problems that you would have in Harrisonburg, Virginia, is you'd have to do what they did in Indiana. You'd have to do a survey, find out which conditions are picked up in newborn screening. What conditions cause dystonia? And I just told you 3 that cause dystonia within this community. What conditions cause mental retardation? So you begin to accumulate knowledge, but you have to do that with the intent that as a clinic, you're going to store that information and use it in your medical practice. And you get information from University of Virginia, you get information from the Clinic for Special Children, but you gather the information with the intent that this is a medical home where people can come and be cared for, but where new cases can come in and they're more likely to be recognized for what they are. It just makes the practice of medicine a lot easier. Usually the people who come to attention first are those who have trouble, and they're coming to you because they have trouble. You know, nobody brings in Sevi Health and Children and says, I want you to prove to me they're healthy. You know, it is the practice of medicine, and there are ways that people come in and ways that you learn that really, I think the most important principle of it is that you have a place where that information is accumulated. Now, a great example of that is that we've been doing exome sequencing. So we do, in cases like the children that we diagnosed there, we found those gene mutations by sequencing all 30,000 genes. That was done at the Broad Institute in Boston. We had a collaboration going with them, and they were the ones who gave us the information that we could look at and say, this is in the ARDR gene. Now, when you do exome sequencing, you get a lot of information that you put in a database. So now we've done over 300 exomes. We've done complete gene sequencing on 300 individuals. And in those individuals are information about diseases that we haven't seen yet, but they're carriers in the population for deafness, for example. And I can go to Dr. Puffenberger, who runs our lab, and say, give me a list of all the mutations found in the exome database that cause hearing loss. It takes him 5 minutes to pull that out. I can see inflammatory joint disease. I can say seizures. Anything that I give him, he can go into that database and pull out information that helps me as a clinician to know what the risks are in the population that we haven't even seen yet. So again, the tools of modern genetics are pretty amazing now. And their application within these small populations, in the sense that I've been talking about them, can be very valuable. You know, many of these families had gone for years and years. It's been hundreds of thousands of dollars going to all the big universities to try to find out what was the matter with these children. And it was really working within the community and accumulating information and putting cases together that allowed us to do what we call mapping studies, that allowed us to gain insight into how the health of the community was being affected.